When Sabas asked me to do this topic, I told him that, come on, we don't do that many. And this is exactly right. Elbow arthroscopy for trauma is an advanced indication. It's definitely not what you should do as your first cases with elbow arthroscopy. And a fracture dislocation like this might seem tempting some way, but you have to understand that we're scoping within the joint capsule. And when you have a fracture dislocation, the joint capsule has ruptured, and when you go in with arthroscopy, you will have the brachialis fall into view very soon, and you will not be able to do anything. So one thing is that fracture dislocations more or less are off. Another thing about arthroscopy is the positioning of the patient. Usually we do elbow arthroscopy in a lateral decubitus or prone position, but this comes with some problems. You cannot easily convert to an open approach if you need to, especially a lateral or a medial approach. It's difficult to assess the stability of the elbow at the end of the case, especially because the joint is swollen. And setting up your fluoroscopy is also more difficult. Having said that, if you want to start with something, I would suggest starting with radial head fractures and the more simple ones. You have to do a CT scan first to make sure that what you see on X-ray is actually what you're treating, and also you have to pre-estimate your screw lengths. The first step is to clean the joint of any hematoma. Putting your lateral portents correctly is very important. You can have lateral portals either proximal or distal relative to the humerus. The more distal you are, the more you put the radial nerve in jeopardy. And this is how they look from the inside of the joint, proximal and distal. Now, in a diagnostic arthroscopy or in any other arthroscopy other than trauma, you prefer to be proximal. This is the capitellum on your right, and you try to be proximal to be safe. But if you're treating a radial head fracture, like in this case, this is going to be your working portal, so you actually have to go distal. And I would say that the joint line is the most distal you can go with regards to safety. Sometimes also you will have a plica, like in this case, or a fold, a synovial fold, which you need to clean. You have to make sure that you clean sparingly, because you'll have fluid coming out of the joint if you take down a lot of anterior capsule. And also it might be helpful to use retractors, to use a more proximal instrument to keep your capsule away from what you want to see. If you have a posterior fragment, you can go also through the soft spot portal. Now, the next step is to disimpact the fragments. This is not going to always to be easy. With radial head fractures, sometimes they are very impacted, and you might need to abort the case because you cannot disimpact the fragments. After you've done that, you can put your screws percutaneously with the guide wires. Removing bone fragments is a good indication, I think, for wrist arthroscopy. If you have a small fragment that you can reach out and remove, or even a larger one, you can use a clamp and remove one, but at the end of this, you have to make sure that you have a stable elbow, and I'll show you just in a little while how you can do that. And you can also have to make sure that the rest of the head doesn't catch the soft tissue in pronation and supination, and you get complaints for your patient. Another indication that is becoming more popular in recent years are coronoid fractures. This is an example of a fracture dislocation. It doesn't look like that bad on X-ray, but if you see the CT scan, there's a small radial head fracture. There's also a capitellum fracture and a small coronoid fracture. And the question for me, when you see the 3D scan, you can see that the radial head is in posterolateral subluxation relatively to the capitellum. And the question here is it better to fix the coronoid or fix the lateral collateral ligament? And I would, in a small coronoid fracture, I would always opt to fix the lateral collateral ligament. Now, if you decide to do the coronoid fixation arthroscopically, usually we use the medial portal as the viewing portal, but through the medial portal, what you see in the back is the radial head, it's not the coronoid. With the medial viewing portal, you cannot see the coronoid well. You have to change your viewing portal to a lateral viewing portal, and now you can see the coronoid quite well. Try to reduce it, and then you can fix it either with cannulated screws or with sutures, but I think you have to be better than me with arthroscopy to do that. Cannulated screws, I think it's the easier way to go. These are also some examples from the literature. You can assess lateral instability with arthroscopy as well. You can assess whether the LCL is torn with arthroscopy. We love this lesion in this seminar. We present it every time. It's rare. It's called the Osborne-Coterie lesion, and it comes from the impaction of the radial head on the posterior part of the capitellum. And a patient that has this sign most probably has torn lateral collateral ligament. But if you want to make sure, what you need to do with arthroscopy is either put a 5mm probe or your shaver and try to push it between the radial head and the capitellum. If it passes through, then you have a LCL tear, or try to do a drive-through test, go from the posterior part of the elbow between the capitellum and the radial head to anterior. Normally, you shouldn't be able to do that with a 4mm scope. If you can do it, then you probably have an instability. There are reports of arthroscopic fixation of the lateral collateral ligament. Christos Koukos has published on reconstructional, but I think Christos is more or less the same technique. You can use it for acute repair if you need to. And that's one option. You can look up Christos' article for the exact technique. Also, you can put a bone anchor and just grab your sutures and put a sliding knot and put your LCL down arthroscopically. Now, there are some more advanced indications. There are reports of capitellum or coronal shear fractures being treated arthroscopically. This is Mike Hausman's case, and after you reduce it, you can put cannulated screws. Also, pediatric lateral condyle fractures treated arthroscopically, but fixation here is with K wires, again from Michael Hausman. And pediatric radial neck fracture dislocation reduction. I personally don't have any experience with those. What we do have some experience with is pediatric osteochondral fractures in OCD. I understand there's a whole talk about this right after this, right after mine. Just 2 points that might be different. We prefer to go with a 2.3mm scope, a wrist scope, from the posterior portal to assess this. First you find your crater, and then you look for the osteochondral fragment. Most of the times you will need to remove it. You will not need to put it back in place. Also, with the same approach, you can find loose bodies and remove them. And then what you do is Fargion crater, clean it, and drill it, usually with a strong needle. There is some literature about arthroscopically treated fractures. Results are good, but these are very well-chosen cases. It's not for general use. If I have some tips for this, one is to delay for a couple of days so that you don't have too much hemorrhage. Keep your pressures low so that you don't get too much swelling. and make sure that you have a plan B. But in any case, what is your priority is to end up with a stable fixation and a stable joint. If the technique is of no importance, so if there's any question about your stability, just convert to open and get it over with. Thank you.